Thank you, and it's a real honor to be here, and I'd like to thank the organizers for including this talk as well as this topic in general. So again, thank you. So I wear several hats. I direct the Partners Pediatric Multiple Sclerosis Center at the Massachusetts General Hospital, which is a large center dedicated to children with neuroinflammatory disorders. And as well, I direct the CLIMB study, which is a large longitudinal study of about 2,000 adult MS patients. And I'll be referring to some of the work from that. And then I also have a research laboratory. So here are my disclosures, and I've served as a consultant over the years for several pharmaceutical companies, and I've also served on clinical trial advisory boards, particularly in relation to pediatric MS. We received funding for the CLIMB study from various companies, as well as from the National MS Society and NIH. So I'd like to begin with a case, and this is a case of a young girl, Anna, who at age 11 presented to her pediatrician with subacute onset of right leg weakness. And this had been going on for several weeks, and I think finally the mother brought her to attention, and subsequently this led to an MRI and further evaluation. It also came to light that about a year ago she had an episode of right arm numbness, which lasted for a couple of weeks, and this went undiagnosed and really was not brought to medical attention. And then her evaluation, we did a number of tests. However, CSF testing showed oligoclonal bands, MOG antibodies were negative, and aquaporin 4 antibodies were negative. And here is her MRI, and I think you can see on the brain MRI there's a number of T2 lesions in the periventricular white matter, which really are classical for multiple sclerosis, as well as a lesion in the cervical spine. And she was subsequently diagnosed with pediatric MS based on the McDonald criteria. She was started at that time on beta interferon 1A, and she experienced transaminitis. No one likes injections, so adherence was a challenge. And then she experienced over the next 1.5 years 3 relapses, which were related in part to non-adherence, but resulted in some motor symptoms. And this was a time where we had few treatment options, so that we were limited in terms of treatments for her disease. Her exam at that time was significant for right leg weakness and gait ataxia. A couple of years later, we were able to start her on rituximab, and she had 1 moderate relapse with no new MRI lesions, and we decided to keep her on therapy, and now she's been doing very well for the next 2 years. She does have an exam with minor issues, some imbalance with prolonged walking. She fatigues easily, and she had cognitive impairment and is slower than her peers. So this is a fairly typical picture of a young patient with multiple sclerosis. And what we've learned over the past 15 years since I've been working in this field is that, as Dr. Wabant has outlined very nicely, that there are similar risk factors for pediatric and adult MS. And we now think of it as a continuum of disease. And now that we can distinguish pediatric MS from other similar disorders such as MOG and aquaporin 4 disease, we're now more confident in the diagnosis. And here we can also postulate that maybe puberty and maybe obesity and dietary factors may herald an earlier onset of disease than was previously recognized. So with this background, how do you treat children and adolescents with MS? Do you use the same therapies as adults and use them just carte blanche? And of course, we all take the Hippocratic Oath to do no harm. And we are, however, limited in terms of the data available in pediatric MS, including phase 3 clinical trials, as well as information about long-term safety. So to really start to inform our treatment decisions in adolescent and pediatric MS, we have to ask, is this the same disease, and are there differences in the disease course in younger patients compared to older patients and what we typically treat? So there's probably 3 main lessons that I'd like you to take home from this section of the lecture. And one is that there's an increased relapse rate or inflammatory activity in children with MS compared to adults. Secondly, the time to locomotor disability measured by the EDSS scale is somewhat slower in children compared to adults, and that's a good piece of news. However, despite this, a young onset MS patient will have more disability at a younger age than a typical adult patient. And the third piece is to take home is that there are significant cognitive deficits in these young patients with MS, and about 35% have significant deficits and 60% have moderate deficits. And this has been shown in a large series of studies from many groups, including Dr. Krupp as well as Dr. Maria Piamato. So to illustrate the first point, so we know that age and onset affects relapse rates, and several studies, including one shown here from our CLIMB cohort, has demonstrated younger age is associated with a higher relapse rate. And here we stratified patients by decade at onset every 10 years, and you can see over a period of 6 years, there is still a higher relapse rate compared to our older patients. Secondly, younger age is associated, again, with slightly slower time to an EDSS milestone. However, again, this does portend higher disability rates at a younger age. So in their mid to late 20s, these pediatric onset patients could have walking disability and locomotor deficits. And then the cognitive impairment, this is in many different domains, including complex attention, naming, recall, and even younger onset is associated with slower processing speed compared to adult onset disease. So inflammation in a developing brain is likely not a good thing. In addition, MRI studies have demonstrated that there is a higher T1, T2, and gadolinium lesion burden in pediatric patients compared to adult patients. So again, illustrating the point that this is a highly inflammatory disease. And then finally, we've now seen in now large studies that failure of age-related brain growth is impaired, as well as continued brain atrophy, not only of the whole brain, but of important structures, including the thalamus, which is, of course, important for processing speed. So this is prominent in pediatric MS. And when we turn to immunological studies, some work that we've done in our group is to look at T-cell proliferation. And here we see that T-cell proliferation is increased in our pediatric MS patients compared to adult patients, again, illustrating probably a higher inflammatory immune profile. And we have also seen an increased IL-17 producing population of memory cells, again, pro-inflammatory cells in our pediatric patients. Now, other groups have found similar findings, increased numbers of memory cells, pro-inflammatory populations, as well as defective suppressive cell activity in pediatric onset MS patients. So I think we also have to ask, is pediatric MS closer to the true biological onset of MS? And when I see some of my adult MS patients in clinic in their mid to late 20s, they will often complain of, well, I had a mild symptom when I was a teenager, but it went unnoted. Or their MRIs reflect a chronic disease which is likely present years before their first clinical presentation. So there's likely a clinically silent prodrome, but in our pediatric MS patients, they may be closer to that true biological onset. And this is an opportunity to prevent further inflammation as well as neurodegeneration down the road. So when we think about the inflammatory cascade leading from relapsing remitting to secondary progressive MS, our current understanding, as best as we can understand currently, is that there are probably T cells which move into the CNS and cause and react with CNS cells. And here there is damage that occurs, cytokine release, as well as antigens which are secondarily released. And this may induce epitope spreading, induce other effector T cells to move into the CNS. And here that increases the inflammatory load. As we now move into increased inflammation, cells within the CNS are likely activated, including microglia, astrocytes, and other cells, including monocytes, are heralded to migrate into the CNS. And this is probably the substrate for secondary progressive MS, which is notoriously difficult to treat. So here we have an opportunity to prevent disease at its earlier stage, hopefully at onset, and hopefully prevent secondary progressive MS from occurring. So this is really where our mission is, to treat effectively our young onset patients as well as all patients. So we know that adult MS has advanced significantly in the past 20 years in terms of therapeutics. There are over 18 disease-modifying therapies available for adult MS in the United States in different classes. And some of these are intravenous infusions of monoclonal antibodies. Others are small molecules, as well as the interferons. And these all have differing efficacy as well as side effect profiles, which influence the choice of treatment. Now, what we've also learned in adult MS from the large series of clinical trials is that age affects the efficacy of MS treatments. And this was a nice meta-analysis performed by Dr. Bilikovit, the NIH, who looked at all of the clinical trials available and did a meta-analysis of the inhibition of disability progression. And she found that disability was prevention was the highest in our younger patients compared to older patients. So this is really, again, an opportunity to treat and prevent disability by treating our younger patients with efficacious treatments. Another piece of information comes from some of the studies that we've done with neurofilament light chain, which of course has now become more widely available for researchers using the single molecule array assay, or SIMOA. And here we looked at NFL levels in our patients with adult MS, and we also stratified by age. And here we also stratified by whether they had a gadolinium enhancing lesion, were GAD positive, at their serum level, or whether they were gadolinium negative. So we all know that with increasing age, unfortunately, we all neurodegenerate a little bit and we lose a little bit of brain. So this is true for adult patients as well. And in the gadolinium negative group, this did follow the rule. However, we were surprised when we looked at the GAD positive group, and here we found a higher level of NFL at our GAD positive patients at a younger age. So age really affects the association of NFL with GAD positive versus GAD negative MRIs. So it might suggest that our younger patients are having a more inflammatory, maybe more damaging CNS disease, and this again is an opportunity, an important opportunity to treat effectively. And also from these NFL studies that we've done with our CLIMB study cohort, we found that NFL in the first 3 years, shortly after disease onset, was the most predictive for 10-year brain atrophy. So illustrating the point of early effective treatment. So I hope I've been able to share with you why I think that pediatric MS is a highly inflammatory disease, maybe more so than adult MS, that younger age is associated with a higher lesion burden and higher SNFL levels at a GAD-enhancing lesion. Pediatric MS is associated with significant physical and cognitive disability at a younger age, and that disease-modifying treatments might have an age relationship. So this also leads us to the next section, where we should think about how we treat MS patients in general. And are you an inductive treater or are you an escalator? And there's been an ongoing debate of whether you should induce treatment or escalate slowly and do no harm, and maybe go more gingerly. And this, of course, is modified by the risk versus benefit ratio. But I think in our younger patients, again, we're seeing a highly inflammatory, potentially damaging disease, and we need to have more treatment options, particularly in that higher efficacy range. So I've been honored to work with the International Pediatric MS Study Group over the past 10 to 15 years now, and this is a picture of the group taken in 2015, many familiar faces and friends from the audience. And so this group has commented on pediatric MS treatments and regimens over the years. And in 2016, when we had very few clinical trial data available, as well as limited natural history studies, we were more towards an escalating approach. We were escalators. And here we said, well, after diagnosis, and then initiate treatment with beta interferon or glutamer acetate, and then switch only if there are a higher number of lesions that are occurring, and switch to second-line treatments at this point. However, we also should take into account that even with these first-line treatments, that a large number of patients, and this was data from our US network led by Anne Ye, which showed that with these first-line treatments, about 50% of patients were still breaking through therapy and had either breakthrough disease or poor tolerance or non-compliance. And of those who switched to a second line, again, about 50% had required a third-line treatment overall. So again, illustrating the point of a highly inflammatory disease in which we need additional treatment options. So finding or obtaining additional data was also influenced by some legislation, and through legislation both in the US through the PREA Act and the BPCA Act, as well as similar actions in the European Union, required investigation plans for any new treatment, investigation plans in pediatrics for any new adult treatment. And so this landscape led to the advent of pediatric MS therapeutics trials or studies. The IPMSSG also commented and helped with the thinking of how to design these trials, and we did this through a clinical trials meeting in 2012, and here we invited both pharmaceutical companies, regulatory agencies, as well as patient societies to comment on the conduct and design of pediatric clinical trials. So at that time, we came to several conclusions, and it was thought to be important to conduct randomized trials. We did not know much about how to treat pediatric MS, and we designed outcome measures which were meaningful and would meet regulatory requirements, and then we discussed the various pros and cons of trials, and included also cognitive battery, which was developed specifically for pediatric MS, as well as the import of gathering information on growth, development, and fertility moving on, as well as long-term extension studies were also strongly recommended. So this has led to the development of several prospective clinical trials, and here is our current landscape, and several of these trials have been launched, and 2 of these trials have now been completed, and several more are on their way. And this is a detailed look at some of these clinical trials if you're interested in reading more about the details. So the first trial to complete was that using fingolimod, and this is a drug which mimics sphingosine, and it blocks the egress of memory Th17 cells, which, as you remember, were found to be higher in pediatric MS patients from the lymph node through the internalization of the S1P1 receptor. And this drug, of course, has been approved for adult MS since about 2011, based on 2 large studies. And this first study was recently completed and published in the New England Journal. So this was a large effort. This was a double-blind, double-dummy study of fingolimod versus Avonex, or beta-interferon 1A. It was a 24-month flexible duration study, and the target enrollment was 190 patients. It actually over-enrolled because there were patients who were waiting in the wings to be enrolled, and it was felt to be ethical to include them in the study, even though it was shortly completing. The frequency of relapse up to 24 months was a primary outcome measure, and a number of additional secondary outcome measures were including MRI, PK studies, as well as safety and tolerability. And there is a 5-year ongoing extension study. So it met a lot of the criteria that we'd laid out in our IPMSSG statement. So here's the study design, and here are the details. And it's important to note that patients were randomized to beta-interferon or fingolimod, and based on their body weight at study entry, if they were less than 40 kilograms, they received half dose of fingolimod compared to full dose if they were over 40 kilograms. And MRIs were performed approximately every 6 months, and again, an ongoing extension study, which is currently ongoing. So the inclusion criteria reflected our typical MS inclusion, and having at least 1 relapse in the past year was also included. And screening included viral studies, including varicella immunity evidence, as well as ophthalmology exam, EKG, and all of the other testings required for fingolimod. So it was a huge worldwide effort. 87 sites participated, and 215 patients were randomized. And there was a profile of patient which reflected our highly inflammatory disease activity. The mean annualized relapse rate in the year prior was 1.5, which is higher than the typical adult trials. And again, the baseline characteristics, the mean age was about 15 in both groups. And I'll just point out the higher volume and number of gadolinium-enhancing lesions at baseline MRI. So the trial results demonstrated an 82% reduction in annualized relapse rate in the fingolimod arm compared to beta-interferon 1A. And when you look at the Kaplan-Meier curve, 86% of the fingolimod-treated patients remained relapse-free compared to 39% of the beta-interferon arm over the 2-year period. And it's really interesting when you flip the numbers around, and this is what I often relate to patients and families in clinic, to really get a sense of what their short-term outcome could be with treatment. So additional secondary outcome measures demonstrated a suppression of disability progression in the fingolimod arm compared to beta-interferon 1A with 3-month CDP. And then a number of secondary endpoints included MRI outcomes, which demonstrated a suppression of T2 lesion volume in the fingolimod arm compared to beta interferon 1A, as well as gadolinium enhancing T1 volume. And the rate of brain atrophy was also lower in the fingolimod arm compared to the beta interferon 1A arm. As well, there are a number of other analyses which are ongoing, and the first of these in the quality of life scores has also demonstrated an improvement of fingolimod in terms of PedsQL scores compared to the beta interferon 1A arm. So safety analysis has demonstrated that adverse events, any adverse events, were slightly higher in the interferon arm, which was largely driven by injection site reactions and pyrexia, known side effects of interferons. And any SAEs, or serious adverse events, were slightly higher in the fingolimod arm, 16% compared to 6.5%. And I'll detail these shortly. So in general, there were low rates of bradycardia or macular edema in children treated with fingolimod compared to, in general, adult patients. However, notable, there were 6 children in the fingolimod arm who experienced seizures compared to 1 in the beta interferon arm. And here is a slide detailing that. These were termed differently depending on how they were entered into the MEDRA database, but one patient was noted to have a generalized tonic-clonic seizure. It is also noted that most patients continued on treatment and were controlled with anti-epileptics. So this analysis is ongoing, and there is a manuscript in the works to detail the both short-term as well as long-term outcomes of these patients who experience seizures. So other adverse events, so there were 3 cases of first-degree AV block in the fingolimod patients. These resolved without sequelae. The majority of these patients were admitted to hospital overnight and had no recurrence and continued on the drug. There were single cases of these disorders which were associated to the large part with either other concomitant medications or complex medical issues. So we've also looked in detail at lymphopenia and infection-related adverse events, and here, looking at lymphocyte counts in the fingolimod versus beta interferon arms, you can see that the fingolimod patients do receive or reach a somewhat steady state over the study period. There were incidences of lower lymphocyte counts, which then seem to revert upwards. When looking at the incidence of lymphopenia compared to the incidence of infections, there wasn't a strong association. And here the IRRs you can see with different levels of lymphocytes in the fingolimod arm are listed here. So the drug has been approved for pediatric MS in several countries now, and there's ongoing approvals. And in many countries, this represents one of the first treatments available for the disease of pediatric MS. In additional analyses with the adult data has demonstrated somewhat higher efficacy in younger patients with adult MS, and this is patients in either their 20s or 30s compared to the overall cohort, again reflecting this influence of age in terms of medication efficacy. So higher relapse rates, suppression in younger patients leads to higher statistical value. So there are additional trials that are ongoing in the pediatric MS population, and the second of these 2 now complete is one using teriflunomide. This targets the DHODH pathway, which is important for pyrimidine production, particularly in rapidly proliferating lymphocytes. And so this study is called TerriKids, and this is a double-blind placebo-controlled study with a target enrollment of 165 patients. And the primary outcome measure is a little bit different compared to the paradigm study. Here it is time to first clinical relapse. And again, there are a number of secondary outcome measures, including cognitive batteries, quality of life, and MRI values. So there is also an ongoing extension study for the TerriKids study, and the primary study will be hopefully accepted to the AAN, where results will be shared in 2020. So dimethyl fumarate, which may modulate the NRF2 pathway, has also been studied in pediatric MS, and FOCUS is a phase 2 study of the DMF compound in pediatric MS patients. This is an open label study of 22 children, and here is the study design with MRI, number of lesions, T2 lesions as the primary outcome. And here there was demonstrated a suppression of T2 lesions on the on-treatment arm compared to the baseline scan in patients, again, demonstrating a suppression of disease activity. Adverse events in this study included relapse. About 32% of patients had an MS relapse on study, and there were about half the patients had a GI disorder or flushing as well. There is a large phase 3 study of dimethyl fumarate called CONNECT, which is ongoing. I think it's close to completion, and this should read out in the next year or two. Studies using other drugs, so Lemtrada, an anti-CD52 antibody, which is well known in this region, had started a study called LEMKIDS. This was an open label study. This was, however, halted in May of 2019 because of concerns in the adult population of some of the other secondary autoimmune side effects, and this could be important or influence pediatric MS, so it was thought to be more prudent or stringent to stop this study. So anti-CD20 therapy has been a big advance in MS in general, and OPERETTA is a phase 3 trial in pediatric MS of ocrelizumab, and this was launched or relaunched in 2019. And there should be large studies which will read out in the next couple of years. And there's also several ongoing analyses of real-world data sets, as well as open-label studies of rituximab, which will provide important information. Natalizumab has also been studied in pediatric MS, and this is an antibody, of course, to the alpha-4 beta-1 integrin molecule, which prevents transmigration of cells into the CNS. And several groups have published case series, and probably the largest is that from Dr. Ghezzi and the Italian group, who published on 101 cases, and this was an open-label study demonstrating a large proportion of patients remained relapse-free, as well as low levels of disability over about a 2-year period. Of course, it's important to think about JC virus antibody status when considering this drug, and in some studies, about 50% of pediatric MS patients were JCV antibody positive, so again, important to consider and test. A PK study of about 13 patients treated with natalizumab was also recently published, and this was a study which looked at natalizumab serum concentrations as well as alpha-4 integrin saturation on immune cells. And here you can see the relationships over time, fairly stable in most patients. But when there was a sub-analysis done stratified by age, the younger group, so the 10 to 12-year-old group, showed some variation in terms of alpha-4 integrin saturation. So it's important to think about PK and PD, and this is what we're going to gain from a lot of these clinical trials and studies, is the very important information that will relate to dosing. And I think the jury's still out on exactly which dose to use, but this is certainly helpful and important information. In the distant past, we had used cyclophosphamide in pediatric MS, and this was a study published using that compound. And here we found a suppression of relapse rate as well as stabilization of disability scores, very rarely used now in our current landscape of treatment. So to maybe go back to our paradigm of escalation versus induction therapy, and which would you choose now with all of this information, I tend to be an inducer and start with at least second line, or what we traditionally term second line treatment, and would treat my young patients with this now that we have more refined and detailed information that I can share with my families. I will also share a case in which I had a young adult with pediatric onset MS, and recently she underwent bone marrow transplant. This was really her choice, but she said, I'm just tired of disease-modifying treatments, and I've had side effects and issues, and I just want to do this. And she's returned from that in the past month and is doing very well and is very happy that she made that treatment choice. So I think we'll hear more about these much more aggressive treatment options, and it may be important, especially for our younger patients. So again, looking at our inflammatory cascade, I think there's an opportunity to start treatment, hopefully to prevent the inflammatory cascade from progressing into the CNS. And there's also an important need for long-term extension studies from all of these pediatric MS trials, including those which detail safety concerns, infections, long-term risk of other autoimmune diseases, and as well cancer risk. So these are all ongoing in some of the large clinical trials that I've outlined, and as well there are efforts to launch large registries to capture this information. So beyond disease-modifying treatments or immunomodulatory agents for pediatric MS, I think we're also thinking about the use of remyelinating and neuroprotective agents in these young patients, and this will be an interesting new landscape over the next few years, and I'm sure there'll be a lot of exploration here. So based on everything that we've learned over these past few years with clinical trials in pediatric MS and treatment options, the IPMSSG developed an updated set of clinical trial guidelines, which were published last year. And here there were a number of recommendations, and I'll just try to break them down. I think this is going to be fodder for the upcoming debate, so I'm interested to hear how this will work out. But in general, we recommend for regulatory agencies that they launch no more than one phase 3 trial for the same pharmacological agent, and not to have differing opinions, especially between the FDA and EMA, so that we can have a harmonized trial which will enroll these precious and rare patients. And then a number of other recommendations around the importance of pediatric PK studies to inform dosing, as well as the importance of animal studies in the pediatric age range. There were a number of recommendations about clinical trial design, and I think that now that we've learned a lot more about the disease course of pediatric MS, as well as we have now treatment options for this disease in many world regions, placebo is not recommended for clinical trials and should be avoided. And in general, other new strategies for trial analysis or statistical analysis are recommended in order to reduce the sample size, as well as draw from what we know from natural history or adult studies. And safety monitoring recommendations include a lot of what I've talked about, and this should be just mandated for all clinical trials, especially in children. So over the years, we've seen a change in the pattern of DMT use, and this is from our US network study. And here you can see that injectables have become lower or less favored in use over the past few years, and here we're seeing much more use of oral and intravenous treatments, which I'm sure will change even further as time moves on. So some of the lessons learned is that regulatory approved therapies for pediatrics are needed in order to provide safe, effective, and informed therapies, as well as those that are available and covered, hopefully by insurance. Clinical trials in children are challenging but can be conducted, provided that advocacy training and infrastructure are available, and organized groups for rare diseases can make a difference in therapeutic development. And hopefully, again, I've been able to share with you why I think that pediatric MS is a highly inflammatory disease, and why I think that induction therapy is important to consider in this young population, especially now that we have safety data as well. So my approach in my clinic for treating pediatric MS patients is a very detailed discussion of decision-making with parents, as well as especially teenagers want to be involved in this discussion and decision, and then weighing the risks and benefits of treatments carefully. But I generally start with a higher efficacy treatment. Monitoring MRIs is an important part of monitoring response. And if I tell my families that if there are 2 events, either new MRI lesions or relapses in about a year or 2-year period, then 2 strikes and you're out. is my general rule for switching therapies. We also discuss in detail other factors. Contraceptive use is very important to address with your teenagers in particular, and lifestyle, nutrition, exercise, sleep hygiene are also very important factors. And here it's a group discussion both with the neurologists as well as psychologists and family counselors. And we tend to do cognitive testing every 1 to 2 years. And I think the final word I'll share with you is transitioning treatments in pediatric MS and young adults. So this rule of younger age is associated with a higher inflammatory relapse rate. Also is applicable when we're thinking about transitioning from treatment A to treatment B. And I've observed in my clinic, I'm sure others who treat children have as well, that there is an early rebound when you're transitioning off a drug to another drug. So does that mean that you shouldn't use drug A at all? Or I think really that you should maybe consider transitioning to a new drug more rapidly. And I've had a patient who had a relapse within a week of stopping fingolimod, so that has now led me to treat or transition 1 day after. So I tell my patients, if you're stopping drug A on a Monday, then you're starting drug B on a Tuesday. So also consider rituximab use, and I've been looking at this in younger patients, and I think this will come out as some of the clinical trials will read out, is that consider shorter intervals for redosing. Again, younger bone marrow, highly active, and earlier repopulation. So I thought this was appropriate given our region. And I'd like to thank our patients, our collaborators, sponsors, and this is a picture of my clinic team, as well as the International Pediatric MS Study Group has been a very important collaborator in many of these clinical trials. This is a website which has a lot of information for both families as well as providers, and any of you who are interested in pediatric MS and learning more are welcome to become members. There's an annual meeting prior to ECTRIMS every year. So I'd like to thank you for your attention, and I'm happy to take any questions.